Hello my geniuses, welcome to another clinical lecture series. Today is your great science tutor Lorenzo, and today we'll be talking about the upper motor neuron lesion today. So the last slide we talked about the manual muscle grading or the motor power grading, and one before that time we talked about the GCS, which is the glaucoma scale. So now we'll be talking about the upper motor neuron lesion, and after this one I'll talk about the lower motor neuron lesion, because this one occurs in the brain. When the brain is damaged due to trauma, it could be disease, it could be any stuff that damage the neuronal activities or damage the cortex of the brain. When it damage the cortex of the brain, it affects so many physiological action of the body. So that is what we want to talk about in this video. So if you are new to my channel, make sure to subscribe and turn on your post notification button, so at any time I drop any video you'll be sure to be notified. If you want me to make a video for you, drop it down in the comment section. I promise you I'll make that video solely for you. So let us jump right into the video now. So now we are talking about the upper motor neuron lesion. So upper motor neuron lesion. So where is the upper motor? The upper motor is between the brain and the spinal cord. The connection or the neuronal transmission between the brain and the spinal cord. So if I could define it, that is an easy way to say it, between the brain and the spinal cord, because neurons transmit information from the brain, which is the central socket where impulses are interpreted and executive function are given, while the spinal cord is just a means of transmitting it to the outer part of the body. Are you getting now? Which is affecting the muscles, the organs, every part of the body through the spinal cord. So now, what is an upper motor neuron lesion? This refers to the damage that affects the motor neuron that is originated from the cerebral cortex, the brainstem, and descend to the corticospinal corticobulbar tract to influence the lower motor neuron. An upper motor neuron lesion is a damage that is affecting the upper motor neurons. Are you getting now? Which originate from the cerebral cortex, from the brainstem, and they descend to the corticospinal and corticobulbar tract, influencing the lower motor neurons. Are you getting now? So the upper motor influences the lower motor. Upper motor originates from the cerebral cortex or the brainstem. Are you getting now? So it's not only corticospinal, corticobulbar. It could be any part. It could be the cerebrospinal. Most of the descending pathway, if they are damaged, it can cause what we call a lower motor neuron lesion. Are you getting now? So the damage to any part of the descending tract will cause an upper motor neuron lesion. Are you getting now? Because this carries the impulses that in which the brain has already executed from the brain to the spinal cord, so it will influence the nerves to carry out the action. So the connection between the brain and the spinal cord is through the upper motor neurons, and the upper motor neurons are usually the descending tracts or the neurons located in the brain. Are you getting now? So that is what we call the upper motor neurons. Are you getting now? So the upper motor neuron usually influences the lower motor neuron. So the lower motor neuron are coming from are leaving the spinal cord. The lower motor neuron are leaving the spinal cord, while the upper motor neuron brings information from the brain to the spinal cord. So hope you understand very well. So I took my time to explain. Upper motor neuron connecting the brain and the spinal cord. Are you getting now? Why the lower motor neuron leaves the spinal cord to what supplies the body structure. Now, upper motor neuron do not innervate muscle directly. I told you it only influences the lower motor neuron lesion, which leaves the spinal cord to ramify on the muscle and give them the signals toward the neuromuscular junction. So now they help to regulate voluntary muscle. So voluntary muscle movement is always influenced by the brain to the area 4, area 6, area 3, 1, 2. So area 4 is the primary motor cortex, area 6 premotor or supplementary motor cortex, while area 3, 1, 2 somatosensory area of the brain. So this brings information from the cerebral cortex and stimulate the ventral horn of the spinal cord. So when they stimulate the ventral horn of the spinal cord, what happens? It is leaving to the lower motor neuron, which is the muscular nerves, to the neuromuscular junction, innervating the muscle. So what do we want? Voluntary muscle movement. 2, we want to maintain the tone. So we are looking at the voluntary muscle movement, we are looking at the muscle tone, we are looking at the posture, we are looking at the reflex activity, and we are looking at the skilled motor control. So when we are looking at the upper motor neuron lesion, these are the functions of them specifically: voluntary muscle movement, muscle tone, posture, reflex activity, and skilled muscle control. The next one you are doing is the anatomy of the upper motor neuron. You get me now? The anatomy of the upper motor neuron. Remember, I said the upper motor neuron arises from the what motor area of the cerebral cortex and transmit down to the spinal cord to influence the lower motor through the ventral gray horn. Again, the upper motor neuron originates from the cerebral cortex and what ramify in the anterior gray horn of the spinal cord to influence the lower motor neuron, which is a spinal nerve coming out from there. So first of all, so where do we have, where is the origination of the upper motor neuron? Remember, I told you that first of all, the upper motor neuron interacts with the basal ganglia for modulation and removal of what unwanted motor movements. First of all, so after it work with the basal ganglia through the putamen circuit. Are you getting me now? Through the putamen circuit. So you go watch my video on the basal ganglia, so you have to understand it as a clinical student. First of all, the cerebral cortex to area 4, area 6, area 312 give information to the what basal ganglia for modulation using dopamine and removing unwanted motor movement. So from here now, when it goes back to the cortex, it goes down to the cerebellum, where impulse of proprioception is brought out from the spinal cord to the cerebellum, so that the movement can be edited. So we want to edit the movement so that to balance the body during movement. We want to balance the body, so the beta ganglia have modulated it already using dopamine. The cerebellum now is editing it to allow the movements to be coordinated. That's what the cerebellum is doing. So now when it goes back to the cerebral cortex, so it now descends to what we call the corticospinal and the corticobulbar. Corticospinal and corticobulbar are the what? They are the paramedial what pathway. They are the paramedial what pathway that ensures voluntary muscle movement. So now it originates first of all from area 4, which is 30% from area 4, 30% from area 6, 40% from area 312. 30% from area 4, 30% from area 6, 30% from area 312. Are you getting me now? So when the impulses come from these areas, are you getting me now? It forms a corona radiata. So it forms a what we call a corona radiata. So now which cells in the cerebrum is giving these impulses? The bed cells, which is the large cells in the inner cortical layer, or the large cell in the inner paramedial layer of the cerebrum. So that large cell called bed cells start giving these impulses that are passed through the basal ganglia to the cerebellum. When it has passed through all this place, it now gives the last information, forming a corona radiata and descending to the posterior limb of the internal capsule. So when they form a corona radiata, they leave the cerebrum, passes through the internal capsule. Which part of the internal capsule? The posterior limb of the internal capsule. So when they pass through the posterior limb of the internal capsule, they descend. I get them now, passing through what we call the cross cerebri of the midbrain. So they pass through the cross cerebri of the midbrain. Then when they pass there, they passes through the pons also. When they reach the pons, they now in the medulla, they have to dissociate in the medulla. What's the meaning of dissociate? They crosses to the other side, like in the medulla now. Now in the pontomedullary junction, in front of the medulla, you have two elevated parts. You have two elevated parts called the pyramid. Are you getting me now? So there's a pyramid there. So that pyramid, they have two pyramids that is in the front of the medulla, in the front. While at the back you can see the elevation of the nucleus gracialis and nucleus cuneatus. So that nucleus gives an elevation at the back, while the pyramid gives an elevation at the front. So after the pyramid, you can see the olives by the side. That is the anatomy of the medulla. So you go watch my video on the anatomy of the medulla. So when they dissociate, only 70%, 70 to 80% dissociate in the pyramid. 70 to 80% dissociate in the pyramid, while 20 goes down and continue at the anterior corticospinal tract. So you have lateral corticospinal tract, which is formed by the dissociation in the pyramid, while those that do not dissociate, about 20 to 30% continues at the anterior corticospinal tract. Both of them help you to do one thing, which is to perform what we call voluntary muscle movement. All of them, they ramify in the ventral horn of the spinal cord. So now originated from the bed cells in the cerebrum. Bed cells in the cerebrum in the inner paramedial layer, forming a corona radiata, descending to the posterior limb of the internal capsule, pass through the cross cerebri of the midbrain, pass through the pons, and dissociate in the pyramid of the medulla. So the one that dissociates stimulate or continue at the lateral corticospinal tract, and the one that do not They do not dissociate, continues at the anterior cortical spinal tract. When they end in the ventral horn of the spinal cord, then the alpha and gamma motor neuron in the ventral horn of the spinal cord now carry out the information to the ventral roots, the ventral nerve, and now the spinal nerves. That is how it works. Are you getting me now? So this is the upper motor neuron pathway. So any damage to the communication with the basal ganglia, or to the communication with the cerebellum, or to the communication with the spinal cord will cause an upper motor neuron lesion. So what is the function of an upper motor neuron? An upper motor neuron, number one, they initiate voluntary muscle movement. I give you, they initiate the voluntary muscle movement. Two, they use this for fine skills, so fine and what skilled movement. So fine and skilled movement, that is the second one. Three, they regulate muscle tone. They regulate muscle tone. Four, they suppress primitive reflex. So all the reflex that's supposed to have gone while you are growing up, they have to suppress it. And also they coordinate posture and what balance. This is what they do. So the next one we want to do now is the cause of what? Upper motor neuron lesion. So what is the cause of upper motor neuron lesion? So the cause of upper motor neuron lesion is simple. Number one, it could be from the brain. So the brain can be the cause. It could be an ischemic or hemorrhagic stroke. So what is ischemic or hemorrhagic stroke? Ischemic stroke occurs when there is a clot in any of the blood vessels, in the cerebral blood vessels, preventing blood from going to supply the brain tissues. That can give you ischemic stroke, and it occurs for about 80 to 90% of all strokes. Hemorrhagic stroke is when the blood vessel bursts and the blood starts leaking out to the brain tissue. That occurs in 10% of the time when there is the great trauma to the brain. Are you getting me now? Now, it could be stroke, it could be brain tumor, a space occupying lesion that occurs, forming a tumor pressing on the area 4, area 6, area 3, 1, 2. It could be from cortical causes, a spinal tumor, it could be a meningioma, or the tumor pressing the brain directly. It could be in the meninges, or it could be on the brain itself. It could be an abscess too. Are you getting me now? It could be an abscess that is formed, that is pressing on this motor cortex of the brain. It could be a TBI, which is traumatic brain injury, something maybe doing an accident, or doing when somebody hits their head on the wall, which is not a motor accident. It could be you fall down from the shower, anything that causes traumatic brain injury. It could be from cerebral palsy, which occurs when the patient is young, it's congenital inside the womb, maybe something happened causing brain bleed, or causing, it could be an infection that damage the motor cortex, usually the area 4, area 6, area 3, 1, 2. It will cause it. And the last one, multiple sclerosis, which caused by when the neurons, the cerebral neurons, are demyelinated. You get it now, because you have the cerebral neurons. These are neurons that connect one part. We call them association neurons. It could be the association neurons that are affected. It could be the projecting fibers. It could be any part of the fibers that are affected. So when they are affected, what do? Are you getting now? When there's demyelination, remember the oligodendrocyte myelinate muscle neurons in the CNS, while the Schwann cells myelinate neurons in the peripheral nervous system. So when there is damage to the oligodendrocyte and demyelination occurs, it could cause what? Multiple sclerosis. We'll talk about all this in our video with time. It could be from spinal cord causes. Are you getting me now? It could be from spinal. It could be SCI, which is spinal cord injury. Maybe there's any trauma, accident that occur, cause a complete, incomplete, or branch-quid transection of the spinal cord. It could be a cervical spondylitic myelopathy, which means they call it a spondylitic lesion, which is usually arthritis to the spine. Or it could be a spinal cord tumor pressing on the spinal cord, hemangioblastoma. It could be anything. It could be any condition. Or it could be a transverse myelitis, which is an infection that affects the spinal cord. Now, it could be a neurodegenerative disorder. So what are the neurodegenerative disorder? It could be ALS. So what is ALS? Amyotrophic lateral sclerosis, which is an which causes an upper and lower motor neuron lesion also. Are you getting now? ALS. It could be primary lateral sclerosis. It could be Parkinson. Now, it could be Parkinson disease. It could be anything that causes what? The upper motor neuron to damage. It could be anything. So now, what will be affected at this particular point in time? Now, remember the reflex arc. I get him now. The reflex arc, you have the receptor. Where are the receptor? After you have given the final information to the ventral gray horn, which contains alpha and gamma cells, what happens? Now, in this axis, indirectly can be affected too. The arc can be indirectly affected. The muscle spindles, which are receptors, motor receptors, which carries proprioception, stimulate the afferent neurons, which is sensory, which stimulate the spinal cord, which is the integration center, and continue to the efferent neurons, which is the motor, and now give the effector, which causes the muscle to contract. Are you getting me now? So this produces what we call muscle contraction, and any part that is affected in this place will cause the muscle not to work again. Are you getting me now? So I hope I made sense now. So the key point you have to note that the upper motor neuron lesion occurs along the motor pathway. It could be the interaction with the basal ganglia, it could be the interaction with the cerebellum, it could be the interaction with the spinal cord. Any part of the motor pathway, if there's a damage there, it causes upper motor neuron lesion and symptoms. Now it also it almost gives the same characteristics with an upper motor neuron syndrome, and also now remember I said the upper motor neuron influences the lower motor neuron. Are you getting me now? So when the upper motor neuron is not active, there is no inhibition of the lower motor neuron, whereby the lower motor neuron will act on its own in an exaggerated way, and this is what you cannot control. This is what will give an exaggerated response, which we'll be talking about in the next part. Now the key symptoms here is weakness. Patient will have prolonged weakness because of reduced neuromuscular transmission. 2, patient will have spasticity because of over exaggeration, increase in muscle tone due to the reflex arc pathway between the muscle spindles. There will be hyperreflexia also due to the interfacial muscle fibers acting very high. It could be a Babinski reflex, which is also a primitive reflex that should have gone, but it will show up. Now one thing you have to know, careful neurological examination helps you localize the site of the lesion and what causes the lesion. When you do your history taking, your subjective history taking and your objective analysis, it will help you localize the lesion, which we'll be talking about how we can assess patients with all this condition. So the next one here is, what are the clinical symptoms that you see with an upper motor neuron lesion? What are the clinical symptoms we can see? Are you getting me now? So the first one will be a weakness. So what do we call weakness? Weakness is called paralysis. Are you getting me now? Weakness can be called paralysis. It could be hemiparesis affecting half of the body. It could be paraparesis affecting the lower limb. It could be quadriparesis affecting the 4 limbs at once. Are you getting me? Now it could be what? Hemiparesis, half of the body. It could be paraparesis. Para means the lower limb. It could be quadriparesis, the whole 4 limbs, or it could be diparesis, which means affecting 2 parts, either the upper limb, you are the upper limb, both of the body. Are you getting me now? So now, what is weakness or paresis? Muscle weakness occurs due to loss of descending motor neuron. So why is there weakness? Remember, the corticospinal tract allows voluntary action. So when there's no voluntary action or there's less neuromuscular transmission, what happens? There'll be muscle weakness. So due to muscle strength is always gotten when there's increased neuromuscular transmission, where the nerve, the lower motor neuron is influencing the muscle to contract. So when that is not seen, what happens? There'll be muscle weakness. There will be extension weakness in the upper limb, flexor weakness in the lower limb. Are you getting it now? Extension weakness in the upper limb causing what? Flexor synergy. So the flexor muscles in the upper limb will be strongly stimulated, but the extensor will not be strongly stimulated in the upper limb. In the lower limb, the flexor will be weak, the extensor will be high. All extensor muscle in the limb will be high, but in the upper limb, all flexor muscle will be high, the extensor will be weak. Now the patient will have difficulty in walking and fine motor movement. So there will be difficulty in walking and fine, because the limbs are flexed, because the lower limb are extended and the upper limb are flexed. Are you getting me now? So there will be weakness or paresis first of all due to decreased neuromuscular transmission. 2, there will be spasticity. Alright, now spasticity is velocity dependent. Velocity dependent in the sense that there will be increase in muscle tone only when you are applying high velocity. So when you are moving the limb very small, there you will not see any tightness. There will be no tightness in the muscle when you are moving them. But when you now add velocity, you are not increasing velocity, you see a clamp knife phenomenon. You see a clamp knife phenomenon when you are trying to use velocity to move. Are you getting me? So spasticity is the increase in muscle tone with velocity dependent resistance. So when you are trying to use force to move the upper or lower limb, you see a very strong, so it will give you a cleft line phenomenon whereby it will be very, very tight. So muscle will be very, very stiff. Why? Because of denervation. Now, not even the nervation self, the nerves are, it depends on what is happening, but with the lower motor neuron will be hyper activated, because of there is no connection between the upper motor neuron lesion helping us to what modulate the lower motor neuron lesion. So the lower motor neuron will act on their own, and that will give what over exaggeration. So there will be increase in spasticity. Now, resistance increase with rapid movement. So when you are trying to do rapid movement, there will be what tightness. So you see it in patients that have any upper, like meningitis, encephalitis, cerebral palsy, all this condition, you will see it with them. There will be hyperreflexia. So when you are doing a deep tendon reflex check, so when you want to check your deep tendon using your tendon hammer, like you see now, when you use your tendon hammer, strike on some particular joints or muscle, you see what we call, there will be a jerky movement. There will be a jerky movement called, the reflex will be high, called hyperreflexia. Now if you try it on the knee, you will see a bricks knee jack. If you try it on the ankle, you see a bricks ankle jack. If you try it on the bicep, you see an increase in bicep reflex. In another video, I'll do the deep tendon reflex, and I'll make a video of it. You also see it. So the next one here is, there will be clonus. So what is clonus? Clonus is a rhythmic involuntary muscle contraction after a sudden stretch. So if you take any part of the limb now, you shake it, maybe take the wrist, you do a flexion extension like this now, or you take the ankle and do a dorsiflexion and plantarflexion like you are seeing this patient now, a dorsiflexion and plantarflexion many times. So if you do it and leave it, you see that ankle will be shaking. It will be shaking many times. It will be shaking. It will be moving without control. So when you overstimulate that joint, any joint, if you overstimulate it, or maybe the shoulder joint, you do flexion and extension continuously, flexion and extension, or the elbow, you do flexion and extension, and you leave it, you see that the movement will be continuous. It's always much in the wrist and in the ankle. Are you getting now? So when you do it in the ankle and the patella, you see that there will be continuous. The patient will continue moving without control. So when there's clonus, you know that the patient has an upper motor neuron lesion. So paresis, spasticity, hyperreflexia, clonus, you will know that this patient has an upper motor neuron lesion. Now you have Babinski reflex. What is Babinski reflex? It is an extensor plantar reflex. It's another name for it. So naturally, what will you do now? You take any not sharp object, you take something like a marker or the down part of the tendon hammer or a pencil, and you try to as the patient is trying to so you try to move it in the sole of the foot. You know what the sole of the foot is now. If you push it around the sole of the foot and take it from the heel of the toe. If you carry that pencil or a biro or anything, just move it from the heel of the toe and take it down to the tarsal bones. Are you getting me now? Take it down to the tarsal. Just put a curve. Do as if you are forming a C shape. It's in your screen. It's in your screen. So when you see it now, you just put a curve from the toe down. You continue drawing it from the toe down to the big toe and down to the small toe. You just write like a C there. Now when you write like a C, what will the patient do? Now the big toe will what? Extend, while the small toes will fan out. So it is a normal reflex in babies. It's a normal reflex in babies. We call it primitive reflex, but it goes after they are 2 years old or so. But when you start seeing it in adults, in Babinski reflex or Babinski reflex or the extensor plantar reflex, you know that the patient has what we call upper motor neuron lesion. Now there will be increase in muscle tone. There will be hypertonia. So there will be hypertonia. Where is hypertonia? At this particular point, the muscles will be tight. There will be hypertonia. The muscles will be tight. But if you now use velocity, it will give you spasticity. But naturally, the muscles will be what? Tight, rigid, and resistant at passive mobilization. So when you are doing passive mobilization, you will feel some rigidness when you are moving. So it will not be like a normal muscle that is moving. It will be very, very rigid. Are you getting me? It will be very, very rigid. So in passive mobilization is when the therapist is trying to move the limb by itself. So when you are moving, active is when the patient is doing it for itself. Passive is when the therapist is doing it. So when you are trying to do it, what will happen? You feel like a rigid, a less normal way in which the muscles should have moved. So when you now use force You are trying to use high amount of velocity. The patient will be, now it will be hard for the patient to do it. Even it will be hard for you to move because of the patient has spasticity. Are you getting me? So the next one will be minimal muscle wasting. Naturally, due to movement and feeding, that's what increase what proteogenesis, which means protein will form, help you to form amino acid. So it will break it down to amino acid. Amino acid will be used to form muscles. You will form muscles with this, form cartilages, help you like give nutrition to the joint, and helps you form more muscle mass. Your muscles will be bulky because of you move and you feed. So when this patient has spasticity, there will be minimal muscle loss. There will be minimal muscle loss compared to a patient with a lower motor neuron lesion. So here that due to the patient is not moving, the patient is always on bed, there will be minimal muscle wasting. The next one is loss of superficial reflexes. So remember, the first one we did was deep tendon reflex, where you are putting reflex on the ankle, the knee, the bicep, the brachioradialis, the tricep reflex. So these are deep tendon reflexes. This one you want to stimulate the muscle spindle directly. You want to stimulate the muscle spindles directly. Are you getting now? But in the superficial reflex, you want to just stimulate the dermatones of the body. You want to just stimulate the dermatones to give you some particular reflex. The dermatones and some part of the myotome to stimulate the reflex. E.g., you have the abdominal reflex, upper and lower abdominal reflex, you have the cremasteric reflex, you have the so many reflexes are there, the pupillary reflex, the corneal reflex, so many reflexes. So there will be decrease in superficial reflexes. Now the posturing will be bad. The patient will have what we call flexure synergy in the upper limb and extensor synergy in the lower limb. Flexure synergy in the upper limb and extensor synergy in the lower limb. So the elbow will be flexed like you are seeing it. There will be pronation of the forearm and the wrist will be flexed. Now why is there flexure synergy in the upper limb? There will be flexure synergy because why? It is only the cortex that is damaged. The lesion did not reach the the lesion did not reach the brainstem. So the lesion was only just secluded, maybe due to any of the causes I've mentioned earlier. It is just specifically to the cerebral cortex. Finish. Just the motor area 4, area 6, area 3, 1, 2. That is the only part that is affected. So it did not reach the brainstem. So since it did not reach the brainstem, the rubospinal tract will be overstimulated, causing flexure synergy in the upper limb, and the reticulospinal tract and the vestibulospinal tract will be stimulated in the pons and the medulla to give you the extensor synergy in the lower limb, which you see in extension of the knee. The knee will be extended. Are you getting now? Why the foot will be on plantar flexion? And if the patient is, the gait of the patient will be what we call a circumduction gait. Now you have a circumduction gait, and it will give you what we call an hemiplegic posturing, depending on where it's damaged. If it's a right stroke or it's a right side of the brain damage, which means the left side will have this synergy, causing what we call an hemiplegic posture. But how the gait will be, will give you what we call a circumdotary gait. So the gait is circumdotary gait, while the posturing is what we call the hemiplegic posturing. Are you getting me now? So key thing you have to note here, an upper motor neuron lesion produces a characteristic pattern, which we have said, and always look for spasticity, hyperreflexia, Babinski signs. These are the key things you have to look: spasticity, Babinski sign, and hyperreflexia. And make sure you compare both sides and localize the lesion and look fine for the cause of what is happening. So how can you examine these patients that have one upper motor neuron lesion? So the next is examination of an upper motor neuron lesion. So how can you examine an upper motor neuron lesion? First of all, you inspect the patient. So what are you inspecting for? So in my subsequent video, I'll give you a pure examination of some conditions in the body, a neurological examination of the full. It will be a full playlist video. Are you getting now? You see how you can examine patients that have any neurological action. But this one is just a short a way to examine a patient with an upper motor neuron lesion. First of all, you check the posture. You check the posture whether the patient is on hemiplegic or diplegic posturing. Are you getting that? So next one, you have to check the gait. Is the patient, when the patient is walking, does he walk in a diplegic gait or a hemiplegic gait or a circumambulatory gait? You have to watch. You have to watch for flexure synergy of the upper limb and extension synergy of the lower limb. You have to check for involuntary muscle movement. Again, now that's what you have to check for. You have to look at all this stuff. Now you have to assess the patient tone using the modified Ashworth scale to ascertain the tone, to see whether because it's also a grading system which I'll teach also. We call it the modified Ashworth scale. It's used to check for a patient muscle tone and to check for spasticity. So now you apply passive movement of the limb and assess for whether the patient is resisting. If the patient is resisting too much, you know that the patient has what? Spasticity. Now you assess for muscle power using an MRC, which is the Medical Research Council, which give us to the Oxford muscle grading, which we have done in my last video. Are you getting that? If there is muscle weakness, which means there's reduced neuromuscular transmission, then you assess for reflex. You assess for reflex using your tendon hammer. You can do a deep tendon reflex on any part of the joint. It could be the knee tendon reflex, it could be the ankle reflex, it could be the bicep, it could be a tricep, it could be brachioradialis, it could be the jaw. Do anyone to elicit if there's a reflex. The reflex is over exaggerated, which means the patient is hyperreflexic. Now you also check for Clonus by moving the ankle continuously or by moving the thumb of the hand or the toe continuously, and check whether the patient will continue doing it without knowing. Then you check for Babinski sign. So how can you check the Babinski sign? You take a blunt object and you move it from the heel across the big toe and the small toe in the sole of the foot toe. You take it, draw like a C, an inverted C. I get him now from the heel of the foot down from the big toe to the small toe, and see whether the patient will move the toe upward, like extending the toe upward and fanning out move the toe upward. Check whether the patient will move the toe upward in extension and fanning out the rest of the small toe. If the patient do it, that means the patient is positive for Babinski signs. Are you getting that? So this is what you do: toe upward, and the patient will fan out the small toe, which I've showed you already. So now, like I said, what are the common upper motor neuron lesion syndrome? First of all, we have hemiplegia, which is weakness of one side of the body. It could be caused by stroke or brain tumor, a space occupying lesion. Now it could be paraplegic. What is paraplegic? Only the lower limbs are affected. The upper limbs are fine. Are you getting now? Which is seen in always spinal cord lesion, spinal tumor, or transverse myelitis. So anytime where you have only paraplegia or paraparesis, which means that the issue is in the spinal cord. So in the spinal cord, when you have a spinal cord lesion, an area below the lesion will be affected. Area above the lesion will not be affected. So but when you have a complete weakness of the body, complete weakness of one side, it shows that is from the brain directly and not the spinal cord. So when the patient has quadriplegia, you can see it. Quadriplegia means that there's weakness of the four limbs. So it is caused by a cervical spinal cord injury, a cervical spinal cord injury, which means it could be a C5, C6 or C7 myelopathy. If it's a C5, C6, C7 myelopathy, which means the spinal cord at that area is damaged, which means region below that axis will be damaged. So if it's a C5 myelopathy, which means it will affect an area from C6 down to your S of your spinal cord. Are you getting now? It could be a spinal cord injury, a cervical spinal cord injury, or a cervical spondylitic myelopathy. Anyone could cause quadriplegia. Now we want to differentiate between an upper motor neuron lesion and lower motor neuron lesion. In the next one, I'll talk about the lower motor neuron lesion, but here let us just compare it fast. In the upper motor neuron lesion, there's spasticity. I get it now. There's spasticity. So the spasticity is seen due to the increase in muscle tone. I get it now. But in a lower motor neuron lesion, there's flaccidity there. Flaccidity in the sense that the motor, the tone will be very weak, hypertonia, and it will be flabby in the sense that you can move the limb anywhere. Are you getting now? We'll talk about it in the next one. There will be weakness, spastic weakness in the upper limb. There will be spastic weakness in the upper motor neuron lesion due to paramedial pattern, and there will be flaccid weakness due to peripheral pattern in the lower motor neuron lesion. The next one, in deep tendon reflex, there will be hyperreflexia in the in upper motor neuron lesion, and there'll be decrease or absence in what reflex in the what lower motor neuron lesion, which is hyperreflexia or areflexia. It could be hyperreflexia or areflexia. Now, in upper motor neuron lesion, the superficial reflex may be lost. It may be present or may be lost in what upper motor neuron lesion. In the lower motor neuron lesion, there's no superficial reflex there. Babinski is present in the upper motor neuron lesion but absent in lower motor neuron lesion. Clonus is present in upper motor neuron lesion but absent in lower motor neuron lesion. In upper motor neuron lesion, the muscle wasting is minimal. Are you getting me now? It's minimal because the patient can still even move. The patient can still even move, but his gait will not be nice, and he will have synergy of upper and lower limb, which will affect the movement. But for lower motor neuron lesion, what happens? There is no muscle. There is severe muscle wasting. In lower motor neuron lesion, there is severe muscle wasting. Fasciculation is absent in the upper motor neuron lesion but present in lower motor neuron lesion. I'll teach you about fasciculation when we are doing lower motor neuron lesion. Now, in the pathology of the upper motor neuron lesion, there's lesion above. In the pathology, there's lesion above the anterior gray horn cells. There's lesion above the anterior gray horn cells. But in lower motor neuron, lesion at the anterior gray horn cells, the nerve root, the peripheral nerve, and the neuromuscular junction. So in upper motor neuron lesion, it is from the anterior horn cells up to the brain, so it's between the brain and the spinal cord, like I said. But in the lower motor neuron lesion, there's the lesion that starts from the anterior horn cells down to the muscle that is being what innervated. Localization of the upper motor neuron lesion, like I said, cerebral cortex. Well, when there is a lesion in the cerebral cortex, it will cause contralateral motor weakness. It will cause Babinski, positive Babinski sign. It will cause hyperreflexia and spasticity. Are you getting me now? So when it is the cortex that is damaged, area 4, area 6, area 3, 1, 2. So what will happen there? It will cause contralateral paralysis or weakness. It will cause positive Babinski sign, hyperreflexia and spasticity. If the internal capsule, the posterior limb of the internal capsule is damaged, are you getting me now? It will cause only what we call contralateral hemiplegia. Contralateral hemiplegia. If it's the brainstem that is damaged, what happens? It will cause contralateral weakness with cranial nerve involvement. That's why you will start seeing what we call facial deviation. You start seeing what we call facial deviation. So there will be contralateral paralysis, which is weakness with cranial nerve involvement. If it's the spinal cord that is damaged, what happens? Below the lesion, there will be spastic paraparesis or quadriparesis. If it's below the lesion, this is the localization of the upper motor neuron lesion. To count everything up now in our summary, we will say that the damage to the upper motor neuron in the brain on the spinal cord removes the inhibitory control to the lower motor. Are you getting now? Remember, the upper motor controls the lower motor. It modulates the lower motor. But when the upper motor is out, the lower motor cannot be controlled, therefore they will be exaggerated, causing spastic weakness, causing increase in muscle tone, hypertonia, causing increase in reflex, hyperreflexia, positive Babinski sign, and Clonus. Are you getting now? So the result is what we call spastic paralysis. Are you getting now? And we said that what are the key upper motor neuron lesion sign? Remember, there will be weakness, there will be spasticity that is velocity dependent, there will be hyperreflexia, like I said. If you use a deep tendon hammer or you do a deep tendon reflex, what happens? If you do a deep tendon stimulation, what happens? There will be hyperreflexia. If you use a blunt object to touch the sole of the foot, the toe will move backwards, which will be hyperextended, and the small toes will fan out, showing positive Babinski sign. There will be clonius when you apply a little movement on the toe or the thumb. When you apply a little movement over a long period of time, what happens? It will continue to shake, and there will be minimal muscle wasting. Are you getting now? We have talked about it already, and we compared it with lower motor neuron lesion too. Now, what are the possible causes? Like I say, it could be brain caused by stroke, brain tumor, it could be traumatic brain injury, it could be cerebral palsy, it could be multiple sclerosis, it could be spinal cord caused from the spinal cord injury, cervical spondylitic myelopathy, it could be spinal tumor, it could be transverse myelitis, it could be a neurodegenerative disorder like amyotrophic lateral sclerosis, primary lateral sclerosis, it could be Parkinson's disease, it could be Huntington's disease, it could be Fraser's disease, it could be anything. And how can you localize the syndrome? Like I said, localizing, if it's in the cortex, you will be having contralateral weakness, you'll be having Clonus, you'll be having positive Babinski sign, you'll be having hyperreflexia. If it's in the brainstem, what happens? It will be contralateral weakness with cranial nerve involvement. If it's a lesion in the spinal cord, the part below the spinal cord, if it's any part below that lesion, will be affected. The part above will be spread. Are you getting me now? Now, if it's a complete involvement of the forelimb, it's caused by what we call a cervical cord lesion. Cervical cord lesion is any lesion in the cervical part of the spinal cord. Are you getting me now? So important clinical tip number one, always know, like I've told you, you have to compare both sides. You have to test the tone before testing the power. Testing the tone, I told you, using modified Ashworth scale. Then you test the power using MRC. Now you check deep tendon reflex carefully using a tendon hammer, and you check for differences between normatonia, hypertonia, and hypotonia. Now always perform your plantar reflex using to check for Babinski sign. Now look for spasticity or Clonus. Are you getting me now? They ask the onset, when it started, the progression, and the associated symptoms also. And now take an accurate history. Are you getting me now? Plus a neurological exam will give you a real way to localize the lesion. Are you getting me now? And also you look for an imaging. An imaging, it could be an MRI or a CT. CT will indicate an active bleeding that is occurring at that particular point in time, causing that, while an MRI will show you a space occupying lesion either in the brain or the spinal cord. Remember the posturing, there's flexor synergy in the upper limb due to over exaggeration of the spinal tract, and there will be extension synergy in the lower limb due to over exaggeration of the vestibulospinal tract or the reticulospinal tract. Now, hope it's making sense to you. One thing you have to know, upper motor neuron lesion causes was spastic paralysis, increase in tone, increase in reflex, and Babinski sign positive. And also there's also what we call minimal muscle wasting. So I hope it all made sense to you and you have understood everything I've talked about in the upper motor neuron lesion. So if you are here up to now, make sure to subscribe and turn on your post notification button. Also tell me what you feel about the video. Tell me how you understood it. Are you getting me? Tell me whether it makes sense to you. Time will come, I will also give case study questions that will also help you check yourself whether you are doing well or not. But for now, we are just doing the teachings. Time will come, we'll start doing the case study questions so that everybody who can test themselves whether they are doing good. So use this in your clinical practice. Ask questions on the comment section, and also share to all medical students that will need this video. So I'll be seeing you in my next video on lower motor neuron lesion. Bye bye.